Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we'll be focusing on the emerging role of cerebrospinal fluid-based liquid biopsies and biomarkers in brain tumors. Our first guest is Stephen Bagley from the University of Pennsylvania, who recently published a paper on consensus guidelines for CSF liquid biopsy research. Thank you for joining. So first off, let's provide some background. What is the rationale behind using CSF-based liquid biopsies in brain tumors?
So the rationale is simply that, spinal fluid is, in most cases, closer proximity to the tumor, direct contact with the tumor in many cases. And so you may get higher levels of tumor-derived DNA in the spinal fluid than you would in the systemic circulation. And in fact, there's been numerous studies over the years that have proven that on average, the amount of tumor-derived DNA or ctDNA is higher in the spinal fluid compared to plasma in patients with brain cancer such as glioblastoma. So that's the rationale. In terms of what's been done, there have been a good number of clinical studies now, both retrospective and prospective, that have alluded to the potential utility of performing liquid biopsy on the spinal fluid in patients with gliomas and certainly other types of primary brain tumors that include medulloblastoma and a few others. And if you look at these studies, about 50% of the time, that seems to be the typical number, you will find at least one tumor somatic mutation. So a variant that's present in the tumor's DNA in the spinal fluid. And so that number of 50% tends to hold up across numerous different studies, particularly in patients with glioma. And so if your patient is in that 50% where you can detect a mutation in the spinal fluid, it could be helpful for that patient. It sometimes could lead to identification of something useful for therapy, or it may just be used as a way to detect tumor versus no tumor. You can imagine if you have positive ctDNA in the spinal fluid, probably there's some, tumor activity that's going on. So now what is generally lacking is, a larger study, prospective, larger clinical study to really prove how use of CSF liquid biopsy, in patients with glioblastoma, for example, how that would actually impact clinical management and whether or not it's something we should be doing on a routine basis for our patients. That remains unknown until such studies are done. I will say that there are a couple of recent papers that suggest with the right assay, the right technology, you can have pretty high sensitivity now for detection, of tumor-derived DNA in the spinal fluid of patients with brain cancer. And so I think we are moving closer and closer towards this being implemented in routine practice.
Great, thank you. And can you now discuss your paper in terms of what you did and the findings, please?
We don't really have broad consensus in the field about when in the course of a patient's care we should be taking these CSF samples for liquid biopsy. And part of that is also because we don't have widely agreed upon standards for how to collect these samples in a uniform way, how to process them in a uniform way, if you're going to store them or ship them, how do all of those variables, all of those factors ultimately impact the performance of the downstream assay of interest. And so you can imagine that if there are multiple institutions or multiple companies trying to develop these assays and people aren't really following the same guidelines or playing by the same rules, it could end up being pretty confusing down the line in terms of how to interpret the results of some of these assays. So this paper was the result of a broad effort across the field to try to bring experts together from both academia and industry and try to agree upon consensus guidelines for which pre-analytical variables we should be paying attention to when doing research in CSF liquid biopsy. And pre-analytical variables are essentially any factors, before the assay is run on the spinal fluid sample that could ultimately impact the performance of that assay. So again, these are things like, how did you collect the sample? Was that done through a reservoir, spinal fluid reservoir, like an Ommaya reservoir, or was it done through a lumbar puncture, spinal tap? Was it drawn intraoperatively during a brain tumor resection? That's one example. There are others, including, again, how do you process the sample once it's collected? What sort of tube do you put it in? What temperature do you store it at? So through a 2-year process of many meetings, many discussions, thorough review of the literature, we were able to come up with a list of what we consider to be the key and most critical variables that researchers in this field should be collecting and reporting for CSF liquid biopsy studies. Certainly, the method of collection of the spinal fluid plays a critical role here. And we already know that because there have been several published studies showing significant differences in the yield of cell-free DNA and in the performance of downstream sequencing, depending on whether you collect that sample from the spine via lumbar puncture versus if you collect it from a direct CSF source in the brain that's very proximal to the tumor. And the performance does really differ there. So method of collection and anatomical location of collection is a critical factor. It probably also, depends on the sort of tumor factors. So for example, where in the brain is the tumor located relative to a spinal fluid space? You can probably appreciate that, a tumor that is invading into one of the ventricles and is actually in contact with spinal fluid, you're going to have a much higher chance of detecting, tumor-derived DNA in the spinal fluid of that patient, as opposed to a patient where the tumor is completely surrounded by brain parenchyma and has no direct contact with the spinal fluid. In addition to the location in the brain, the other tumor factors that might matter would be, is the tumor currently progressing? If it's currently growing and proliferating, you're probably getting more DNA shedding. Or conversely, if the tumor is being treated actively, so for example, during the course of radiation, that's a time where there's a lot of tumor cell death, and so you may get more shedding of DNA. The patient who has been doing fine for many months and has no real activity, no real change on the MRI, that may be a case where you might not expect as much tumor-derived DNA in the spinal fluid. So I think that those are really some of the key factors. And then there are many others in our paper that are important, but probably less so.
And for clinicians and researchers who are interested, what are the challenges in the clinical use of CSF-based liquid biopsies for brain tumors?
Yeah, I think that there are several barriers. One of them is it's not so easy to draw spinal fluid as it is to collect a blood sample. The various ways you can do this, including a lumbar puncture or including placing a CSF reservoir in the brain or collecting it during a surgical procedure that the patient needs anyway, any of these modalities are still going to be less invasive than acquiring brain tissue. So that's one of my main arguments for doing it. But it still is much harder than just collecting a blood sample. And this depends on where the patient's being treated and that institution's level of comfort with collecting spinal fluid. And it also depends on how easily and quickly one can obtain spinal fluid. So that's something that I think is just a natural barrier to sort of regular widespread use. And the only way to pick up the use in the field is to really prove the clinical importance, right? If you can show that this really is changing management, then it's not such a big deal to put the patient through a lumbar puncture, but we have to show first how it's important. I think the other barrier is that, it's just what I just said is, if you're going to put the patient through collection of spinal fluid right now, how is that going to impact your management of the patient? How's that going to change what you're doing? And I would argue that there are probably a couple of select clinical scenarios right now where we already have assays that are good enough to have some clinical value. And I would say one example of that is if you have a patient with a new brain mass on MRI and it's in a difficult location to sample, the neurosurgeons feel uncomfortable sticking a needle in that part of the brain, for example, a brainstem tumor. that's a case where right now you could draw a spinal fluid sample, and if you detect a certain mutation in the spinal fluid, you can make a diagnosis without having to put the patient through a very risky brain surgery. So that's a use case where we're already there, and I think it's clear that it impacts management. The I think less clear cases would be, let's say you have a brain cancer patient, again, use glioblastoma as the example, and that person, has had standard of care radiation and chemotherapy, and now they've got some progressing tumor, presumably on the MRI scan. You're not sure if it's actually tumor or if it could just be, benign changes from the radiation. In that scenario right now, it would be great if we had a liquid biopsy test, blood or spinal fluid, that could clearly tell you, yes, that's tumor growth. And if so, get an updated molecular profile on that recurrent tumor. We're not there yet. I think that is where we all want to be, but that's probably the hardest, simultaneously the most important, but also the hardest clinical use to really build this up and prove that it's going to change management. And I think we just need bigger studies, better studies, and ultimately we need better assays that are sensitive enough. But that's where I think ultimately the field will be heading in the coming year.
Thank you, Dr. Bagley. Our next guest is Cecile Riviere-Cazaux from Mayo Clinic, who authored a review of CSF biomarkers for neuro-oncology. Thank you for joining as well. Can you maybe begin with what the take-home messages were from your review, please?
Of course. So our review focused on the state of the field right now in terms of where cerebrospinal fluid or CSF biomarkers are at for patients with brain tumors, including both patients with gliomas and then also brain metastases, as well as other tumor subtypes. There's other really great reviews that have already been done on CSF as a biomarker source for patients with brain tumors. But our review, I really focused on some of the key variables that are not as frequently discussed in terms of the impact of anatomical location, tumor to CSF contact, blood-brain barrier disruption, which is something that we see in many patients with high-grade gliomas, and how variables like that can actually impact a variety of biomarkers that we would be interested in testing in CSF, whether that's D2-hydroxylutyrate for patients with IDH-mutant gliomas, cell-free DNA, which can be relevant for a variety of patients with brain tumors. And then more broadly as well, given how much new research there is in the field of CSF as a biomarker source, we also were really interested in conveying the opportunities associated with that as liquid biopsy source in terms of how it can be integrated with plasma also as a liquid biopsy source, how to think about integrating CSF into our clinical trials and standard of care as we work on developing and validating different biomarker types, as well as then, really common questions and difficulties that are encountered in the biomarker field. Like, one of the main reasons why we're interested in having liquid biopsy biomarkers is because we have such difficulties in distinguishing progression from radiation necrosis in patients with gliomas. But one of the reasons why we have a difficulty in distinguishing them is that we often don't get a tissue biopsy at the time of suspected recurrence. So if we're using a biomarker to be able to differentiate progression from radiation necrosis, what do we use as a gold standard when we're often not getting tissue? So some, considerations like that of as liquid biopsies gain more and more traction in the field, where and how can they be integrated into our standard of care and clinical trials? And, how can we thoughtfully consider variables and benchmarks to be able to validate them?
And looking towards the future, what role do you think CSF liquid biopsies will have in precision medicine for brain tumors?
Mm-hmm. I think it's going to be game changing. I mean, we're still in the very early stages, I think, of CSF as a liquid biopsy source, but I think the ability to detect these very specific kind of molecularly defined biomarkers like cell-free DNA variant alleles, D2H, D2-hydroxyglutarate for patients with IDH mutant gliomas. And then even in plasma, I mean, when we're looking at these amplified junctions, they're often associated with EGFR, CDK4, and other things like that, which can be molecularly targeted. I think one of the limitations that we've had in the field of neuro-oncology, again, has been our inability to access tissue longitudinally. Unlike in other fields like breast cancer, where there's a lower threshold to be able to biopsy and to be able to determine whether or not there is treatment response to a molecularly targeted agent. So I really see CSF and hopefully plasma being able to fit into a new paradigm where we have patients that come with a brain tumor. They undergo either a biopsy or a resection. We get that tissue and we have an idea of, here's the molecular profile. What sort of agents can we use to target these molecular alterations, either with or without standard of care, depending on if they're expected to be, sensitive to those agents. And then putting them on that agent and then using that CSF or plasma before and after the agent to see whether or not there has been on-target effects. The other thing too, of course, when we're thinking about precision medicine and these sort of molecularly targeted agents is the ability to look at treatment resistance. And so I think one of the things that we've been able to see is that, if we target one mutation, there's often a whole outslew of other mutations that can come. And we can see that in CSF. So I think that then lends itself really well to sort of response adaptive trial where we'll put a patient on a therapy that's, specifically ideal for them based on their molecular profile at the time. We can look at the CSF and see, all right, did it have its on-target impact? What's the overall disease burden looking like? Is it going down? Is it going up? And is there new mutations that are emerging that can then be targeted? And I think with all of that information in hand, it'll allow us to have more shots on goal for patients. Right now, our limitation in neuro-oncology has often been that we'll put a patient on a therapy and then wait for outcome measures like overall survival and progression-free survival, which are, necessary overall, but they're really mechanistically impoverished, and we need to have more biological information. And we have patients who are interested in also getting that information to help guide their treatment. So I think the liquid biopsy space is going to hopefully, I think, revolutionize the neuro-oncology pathway, especially for in the context of clinical trials and all this, like these cool new agents that we're getting to see every single year. So it's an exciting time.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.